Anna Pingree. I am a neurovestibular physical therapist for UPMC Centers for Rehab Services, and I provide rehabilitative care to individuals with multiple medical diagnoses as well as neurologic problems. In particular, for cancer survivors, we provide a lot of care in terms of even just general conditioning. Sometimes there are patients that we're seeing who are actively in treatment, who as a result of their treatment have had a loss of function. And we do care even just for wellness in that population, in addition to all the other type of neuro and vestibular diagnoses that we treat. So I'll let Kelsey kind of go through some of the disclaimers, but a little background information about me. I've been practicing for about 25 years. I graduated from Duquesne University with a master's degree, and then I received my doctorate in physical therapy through Chatham University. And for the last probably 15 years, I've done just neurovestibular rehab. All right, Kels.
Yeah, so I just wanted to say a couple of disclaimers, like Helena said, just that this presentation is being recorded. And this isn't necessarily a formal diagnostic of treatment. So if you feel like these symptoms relate to you and you want to look into it further, just consult with your medical professional.
All right. And thanks to my 13-year-old daughter, she puts all the fun things on my PowerPoints. So my objectives for providing this talk is to primarily help our clients understand how our balance system works. We do have cancer survivors that we see who have peripheral neuropathy as a result of chemotherapy and some of the radiation therapies that they receive. And as a result of that, they often are at risk of falling. So we want to make sure we understand risk factors for fall, how to prevent falls, and general safety measures. And probably most important that everybody wants to know is what type of exercises are important for individuals to prevent falls. So if you're talking about balance, balance is, I always say, a lovely symphony of multiple systems working together. When we talk about vestibular function, we're actually talking about the inner ear, and it plays a role in our balance, a huge role, as well as your visual system. Proprioception and posture is what your body is using for sensory input from your feet, your arms, your legs. And then how our brain processes all of that information and coordinates it so that we feel normal, right? And that's basically what we call motor control. And then we understand how we coordinate all those factors together. So my patients that come to me may have a problem in any of those areas as a result of treatment, or just in general, a separate problem in addition to what they're already experiencing. So we define a fall, obviously, as an event when someone comes to rest inadvertently on the ground floor. It's fun when I talk to my patients and I'll say, well, do you fall? And they'll say, oh, no, I don't fall. And I said, okay, well, how many near falls have you had? And they'll say, oh, I do that every day, multiple times per day. So I have to tell them, even like falling backward on a chair, even though you safely land on the chair, it's technically still a fall, right? So we want to make sure we're preventing all of those losses of balance. Some general risk factors, obviously age, but age alone is not the only reason people fall. I have young people falling as well. So as far as gender, older women are more likely to fall, but they also have osteoporosis or osteopenia, so they are more likely to sustain a fracture. And then individuals who are on multiple medications, some of the side effects, number one, all the side effects is dizziness, nausea, right? Those things. So oftentimes if you are taking new medications and you stand up and feel dizzy, you could be at risk of falling regardless of age. And then if you have a very slow walking speed, we call it our fifth vital sign in PT, because walking speed, there's a right speed for each person and we have cutoff scores. So generally it should take you about 7.5 seconds to cross 20 feet. If you are doing that, it should take you really only between 5 and 6 seconds. So if it's taking you longer than that, that 20 feet mark is like when you press the crosswalk and you have to cross the street. If you cannot make it in a certain amount of time, we know that that indicates an increased fall risk. And so we measure that in our patients, and we have good data to support that for all ages, from adulthood, early adulthood, all the way to geriatric. So some of the statistics about falls, we treat 2.8 million. I don't, but we know that they are falling, right? In our emergency departments, they're coming in. UPMC in particular, with our primary care offices, has instituted a falls prevention program where we have our primary care doctors doing screens on their patients and then stimulating referrals to us so that we can stop a fall before it happens, right? But we do unfortunately see people after they fall. Over 800,000 can be hospitalized for injuries from falls. In particular, I see a lot of unfortunately called subarachnoid hemorrhages or brain bleeds from falls, which is kind of like sustaining a stroke from trauma. And then obviously hip fractures. So that information comes from our CDC. So there's internal and external risk factors for falls. Again, age is one piece to this puzzle, but not all of it. So internally, if you are much older or you've had a previous fall, or if you do have muscle weakness or balance problems, right, you're more likely to fall again. Visual deficits and postural hypotension we'll talk about is when your blood pressure drops when you stand up, again, feeling dizzy when starting to stand up. And then any other chronic condition that you may have in addition to what you're already managing for falls. Fear of falling is a big thing and a risk factor for it. So if you're afraid of falling, you're walking slower, you're probably holding on to things. And so we address balance confidence in our patients also. And then we talk about the extrinsic or external factors, which are more your environment, right? How can we improve the area that you're living in to keep it safe? And in particular, we talk about the medications that people are taking because they can lead to falls as well. So what can you do to prevent it? Modifiable risk factors are where we come in, right? Improving your strength, wellness. Thankfully, our healthcare system is somewhat changing from reactive to proactive, and these types of community education programs really do help with that. And improving wellness for our population, for people who are managing any chronic disease. So we want to work on building up strength. We want to work on building up your balance, your ability to walk. We can correct problems with shoes. I look at footwear to see what are people wearing. If your shoes are falling off your feet and they're slip-ons, you probably are more at risk of falling because of that, and especially worse if you can't feel your feet. And then obviously we're checking vision. And in our older population and even younger population, myself with progressive lenses, when you're walking downstairs or you're walking around things, the corners of your visual fields are blurred with progressives. Bifocals, right, looking down can misjudge the step. Have had a lot of patients have a loss of balance because of that. So those are good modifiable risk factors. Love this picture, it makes me laugh. That's sometimes how I feel my house looks like on a Saturday morning after having 2 kids in school all week and working all week. So, but home hazards, what you've got to make sure you have a clear path. I do talk to people about, making sure their common pathways in their home are clear of clutter, wires, cords, things, pets. We talk about that. We have lots of, I love pets. I have a dog and a cat, but they get under your feet when you're walking. So just trying to make sure we're keeping everything as clear as possible. Stairs, right? Everyone has stairs in Pittsburgh, most people. Again, keeping things free of clutter. I go through problem solving with patients about carrying laundry up and down stairs. That's a huge fall risk. But just even the steps themselves, making sure that they're secure, making sure if it's carpeted, that the carpet's not slipping off the end of it. Or if it's not carpeted and they need something to anchor it down to keep it safe, we talk about that. So sometimes patients just come in for a one-time visit and we go over all this information and we kind of troubleshoot and problem solve. And then I'll bring them back in a month and say, how are things going, right? Are you feeling safe? Are you more confident? If they are, great. They don't need to see me. If they are still having problems, then yes, we're going to bring them in more regularly. So we talk about all these falls prevention measures, especially for our older folks, right? And even for me being short, I have to get items from a high shelf. I don't want, if I have a balance problem, I shouldn't be climbing on step stools or standing on chairs and things like that. So we talk about how to keep them safe in every area of their home. Lots of great little falls prevention devices, sturdy step stools with handles, non-slip rubber mats in the tubs and showers, grab bars. And we have great, like I have great resources to tell people. The area for the Agency on Aging provides people that can come and help in the home if you have a family member that you're caring for, or if it's you yourself who needs these adaptations. So some of what we do isn't just exercise, it's a lot of what we do is helping them figure out how to make their living environment safer and connecting with those resources in the community. So then we go through each home. I'll say at nighttime, especially, do you have to get up to use the bathroom? Most patients have to do that. How are you getting up safely? Do you have night lights? Is there something that is a motion detector so that you turn it on? So many people say they don't want to get up at night and put a light on because they don't want to wake their spouse or their partner. It's really hard. I tell them just, you've got to have a motion detector, or sometimes I'll say the little mag light flashlights at the bedside, just to kind of make your way safely where you need to go. So what else can you do to prevent falls? Medications are a big problem for fall risk because of dizziness. Yes, I treat patients who have dizziness as a result of inner ear dysfunction and vestibular problems. But one of the primary side effects when you look at any medicine you're taking, usually dizziness or drowsiness is the one that is listed first. So we talk a lot about that. Communicating with the physicians. We don't change medications, right? Physical therapists cannot prescribe or stop medicines, but we can alert the physicians and the patient that this is a possible problem. So the common medications that cause dizziness and increase fall risk are usually the like the psychoactive medications. Some antidepressants can cause dizziness. Obviously, if you're taking a sleeping aid, it can cause a lower level of consciousness because it's supposed to help you sleep. But then if you have to get up, you can be a little disoriented. And some other drugs like some of the benzodiazepines. However, if you have to take those medications, nobody says you should stop them, but we problem solve what you need to do to manage your balance more safely. And of course, one of the other roles we play is helping people walk with assistive devices, figuring out what the safest device may be for a younger population who may have a balance problem as a result of treatment for cancer. Sometimes I use walking poles because they are much more, I think, acceptable for people to use at a younger age, but they keep you very safe. So if you've ever seen the walking and hiking poles, I like those. I use those a lot with our younger population just as a safety for counterbalance. And in our older population, we do use canes, walkers, rollators. Crutches are not a common device that I use for someone with falls prevention because it's actually quite difficult to walk with crutches. But walking poles have become a fan favorite, and I do really like them because they serve a very good purpose for balance. And the best device really to help someone is the one they're going to use. If I give them a cane and they leave it in the corner all the time because they don't want to use a cane, it's really not helping them. So we figure out what works best for them. So a lot of times it's not the patient who maybe is alerting people about their balance problem. It might be a family member. It might be a friend. If you like to take walks for exercise and your friend tells you every time you go, they're bumping into you on the right side and you're drifting to the right side or the left side, or they notice you're catching your feet, sometimes as an individual patient, you think, I hope nobody notices that. And sometimes you need a friend to be an advocate for you to say, hey, there's help for things like this. We should get you checked. Maybe they can look at your strength, look at your balance. So these are all things we are big, big advocates for keeping family members and caregivers involved in the management of our patients. So there's some really good functional tests, and a lot of what we do in physical therapy, not a lot, all of what we do now is evidence-based. So when I first graduated, we kind of just took for granted that what we do helps people, right? We didn't have to quote prove that it helped people. Now we are very evidence-based in how we practice. So our interventions at that time long ago were still very good. We just didn't keep track of how well our patients got, right? We knew they got better. We didn't measure it quite as closely. In today's day and age for physical therapy and everything in medicine, it's all based on evidence. So we use a lot of what we call functional outcomes measures to determine someone's fall risk at baseline. We intervene with appropriate care, and then we remeasure those things again at a later date. And we see that we have either, hopefully, reduced their fall risk and improved their function. So if you're wondering how well you're functioning, 5 times sit to stand test is one of them that we do. And when I provide these little lectures in person, I actually have the patients try them. I'll say, okay, I'm going to set a timer. Let's stand up and sit down 5 times in a row. Some people cannot get up without using arms on the armrest. That's fine. I can still time you and hopefully show improvement. If you're getting stronger and your balance is improving, you eventually are able to do it without holding on. So in general, if it takes a person longer than 12 seconds to rise from a chair 5 times in a row, you may benefit from an additional assessment with us. And it could just be strengthening. It may not be balance. It might be weakness, right? But this is a good functional measure, and we have age-related normal values that I could compare a 30 and 40-year-old, not to an 80-year-old, right? So that's not fair. We compare to your age group. Even it's separated by sex as well as diagnoses. We have normal measures for each neurologic diagnosis as well as cancer diagnoses. Functional reach is another good safety or balance measure that we utilize for function. Standing like the person is in the photo and reaching, we basically record when they're upright, what's their starting point, and then we have them reach as far as they can, and we record how far they can reach. There's great data to support that if you can't reach at all, we know based on age, more in our geriatric population, this is an older measure, you're 8 times more at risk for fall if you're unable to do that task and not lose your balance. And you do lose your balance, I'm sorry. If it's less than 6 inches of your functional reach, you're 4 times more likely to fall. And if you can go 6 to 10 inches, 2 times, if you're within that range, 2 times more likely to fall. So again, knowing what's normal, what's not normal, comparing you to yourself over time is really what we try to do. But think about that. If you have to reach in a cupboard, you have to reach into the refrigerator, you have to reach into the washing machine. These are all things that we have to do. And if you cannot maintain your balance doing it, you're much greater risk of falling. And another test we do is called the timed up and go. Very functional. How long does it take you to stand up from a chair, walk a certain distance, turn around and come back? It's equivalent basically to what you do in your house to get up, walk to the bathroom, come back, get up, walk to the kitchen, come back. So very functional measures. The cutoff time for that is if you can do it 10 seconds or less, it's normal. And an older individual, if it takes them longer than 12 seconds to perform the task, they are definitely at a greater risk of falling. So these are easy things even family members could trial with a patient at home if you're concerned and you know they're having trouble. And then you can say to them, you know, there's physical therapy, there's help for these types of things. So again, just good measures. And then what's really fun is our patients like to see what their scores are when they're all done with us. And they see that they can do it without any difficulty. Their times have greatly improved. So it's also a motivating factor. So how do we know if your legs are weak? Difficulty climbing stairs, difficulty doing curbs. If you can't get up and off of the floor, obviously, if you have trouble lifting your legs in and out of a car or trouble getting up into like an SUV, right? We know those patients are having difficulty. When we talked a little bit about blood pressure, Blood pressure management is difficult in our patients. Most of the time we're managing high blood pressures, but I just had an individual who was recently discharged from the hospital after a prolonged hospitalization. And in their medical history, they did have a history of cancer and they were not hospitalized for that at the time. However, they have high blood pressure. And when they returned home, they had readjusted all their blood pressure medications and they were having very low blood pressures. And when that happens, they have, we as physical therapists are the ones seeing the patients in the community more frequently. So we reach out to the doctor, make sure that their blood pressures are being managed properly, and alerting the physician that maybe they need to just look at it and record them more closely and make sure they're not getting dizzy. But sometimes you can have a drop in blood pressure just by standing up. And that can be caused by just physical deconditioning, treatments that you're receiving, or any sort of prolonged hospitalization. And so patients will feel dizzy, lightheaded, off balance. They get that blurry kind of tunnel vision, almost the feeling that you're going to pass out, but you don't. And that can be called postural or orthostatic hypotension. It is definitely a problem in our patients. We manage it by a lot of education, making sure that they're getting enough hydration because fluid dehydration is a big precursor for this. Sometimes doctors will manage it by giving them compression hose, like the runner's compression knee-high socks to help with when they stand up and not feeling dizzy. So there's lots of easy ways to fix it. It doesn't always have to be medication. Generally, we do a lot of education with the patient about taking your time to change positions. And again, we talked about staying hydrated. Poor vision is another reason people feel off balance. Certainly cataracts, macular degeneration, other dysfunction like diabetic retinopathy and glaucoma. Those are all reasons people can have less acuity of vision. We rely very heavily upon our visual system for balance inputs. And without that or decreased vision, our patients feel off balance, especially if they're turning their head or they're not seeing clearly ahead of themselves or in the periphery. So like we said, obstacles. If you don't see your pet underneath your feet, then we got a problem, right? Bifocals, trifocals, throw rugs, furniture, clutter, all these things are ways that we kind of troubleshoot and falls prevention for our patients. Outdoors, if you come and see me at any of my offices, if the weather is nice, I'm generally outside with my patients. We have lots of curbs, ramps, stairs, grassy surfaces. I want to see how you function in the community. In my office, everything is completely safe, right? So I need to figure out how are you functioning when you're outside of this office. In terms of, I'll be brief with this, the glasses, bifocals, and trifocals. I always ask patients if they've had a regular well visit for their eyes within the last 1 to 2 years. And if they haven't, and they're having difficulty with balance because of vision being a piece to the puzzle, I do refer them out. I do explain to them that if they are older and thinking about getting bifocals and trifocals, a lot of our physicians recommend against that because of the increased fall risk in learning something new. Now, if somebody's already been in a bifocal and a trifocal, we troubleshoot. I'm not going to go back to single vision lenses with them or say that they have to, but we have to troubleshoot how to teach them to avoid a loss of balance with those types of lenses. So I've done a few talks before about peripheral neuropathy with our cancer groups. One of the number one side effects of cancer chemotherapies, especially some of the taxons, they do have neuropathy as a result of treatment. I have cared for many patients, and sometimes treatments have to be changed because of the severity of the neuropathy. Again, open communication between myself and the physicians that are caring for those patients. Chemotherapy and radiation are life-saving treatments, and they want to provide all of that, but they also are looking at what deficit is going to happen afterwards. And so neuropathy is one of them. We do teach our patients how to manage those symptoms. In terms of balance, we sometimes have to help them with braces or with exercises if they lose function in their feet from neuropathy. Sometimes those changes are temporary and sometimes they are permanent. But even so, right, we can be able to help our patients live a very full, good quality of life, even with neuropathy as a side effect from cancer treatments. Shoes, right? We have to look at our shoes and what we are wearing on our feet. That's a very easy modifiable risk factor for falls. Slippers and slip-on shoes generally should be avoided because people just shuffle their feet in them. We prefer an athletic shoe or some type of shoe that laces up or has a secure like gore gumming on it that you slide into, that is a full shoe. So there's a lot of additional home safety measures for individuals who are at risk of falling. There's a lot of the call systems for people who live alone. We have a lot of other little ideas if there's a caregiver in the house that the patient keeps their cell phone with them or they have a bell or a whistle, things like that, that if you would need help, you would be able to call for help and access it. For somebody who lives alone, we work on setting up those services to come into the home to have like a medical alert system for them. So the types of exercises we'll talk about are, in general, helping with functional activities. I try, if somebody's not involved in an exercise program, we're very good at initiating that with our patients in a safe way, teaching them functional tasks, standing up and sitting down from a chair, establishing a walking program. We do encourage our patients to walk. If they're unsafe without support, we would give them a walking aid. If they need a person to go with them, then we will talk to them about having a family member or a friend take them. But walking and doing some type of something for balance and strength each day or most days of the week is highly recommended for falls prevention. So strength training is a component to keeping patients safe and preventing falls. I love the gymnast photo here to help our patients say that anybody can exercise at any age. Muscle strengthening, according to the American Collegiate Sports Medicine Institute, they recommend strength training 75 minutes to 150 minutes per week with aerobic activity. Now, I would say that most of our population is not doing that. So what I encourage them to do is 10 minutes at a time. I said, do 10-minute little activity in the morning, 10 minutes in the afternoon, 10 minutes in the evening, so that you can get some form of activity in throughout the day. In general, you'll hear me say to every patient, move more, sit less. Incorporating balance activities, something separate to work on balance and challenging that balance center in our brain is also very important for this population. So a lot of our exercises, we have very nice pictures that we give to our patients. They're very basic. We make sure they're safe and independent with everything that we teach them. We customize the program for each individual person. So if you don't have trouble getting out of a chair, I generally won't have to give you that type of exercise. So I will evaluate each person individually and then customize an exercise program for them to keep them safe and well. So the following slides will go through some different pictures of exercises that we may do for this patient population. As I mentioned, they're very functional. Marching and lifting our hips and knees is essential for walking. Again, any hip or leg movement is done for functional strengthening with support for balance if you need it. Sometimes we add weights to the exercises and sometimes we don't. It all depends on what the patient is capable of doing. We do a lot of sidestepping, forward, backward walking, obstacle negotiation in the clinic. Again, taking patients outside, making sure that they're safe. We do, even though a lot of people don't want to just work on standing balance, I'd say we've got to do something to challenge your balance. Most people who are older have difficulty with heel-toe balance, but it's a higher level balance function. It challenges the brain in a positive way. So we do oftentimes ask people to do things that are a little bit more difficult, But by doing so, the brain actually rises to that challenge and improves that balance coordination. For safety purposes, I often have people stand in a corner or in front of a counter or have their caregiver nearby to assist with balance as well. So when should somebody see a physical therapist? If you feel that you're trying your exercise program, no matter what it is in the community, it does not have to be our exercises. If you're trying to start a walking program, you're trying to start yoga, you're trying to do some virtual exercise programs online, and it's not going well, we do have patients come to see us. We talk to their physicians about obtaining a physical therapy referral. And then we can customize their fall prevention program, even if it's just a wellness program for strengthening, for flexibility, for balance, and gait training. So I love fall. It's probably my favorite time of the year. I'm hopeful that we'll get some fall colors with the leaves. It's been a little slow this year. So my contact information is here. If you have any questions, you can always email me. I work in 2 different local offices in the Pittsburgh area and the North Hills. One of them is in Allison Park and one of them is in Wexford. And I work 5 days a week to assist patients with all aspects of their care. Thank you.
Thanks, Helena.